Ready?
So
Okay.
let's.
All right, let's do number 3.
Number
Let's
three.
stay now. We're kind of going from immunologic. Let's go to musculoskeletal with a little immunologic because of diabetes.
Yeah.
So let's talk
because
about
of the HIV, and now we got the. Now we're staying with bone again.
We are. So this is actually a JAMA article. This is one of those. Does this patient
JAMA, if you
have
prefer.
kind of these JAMA? Oh, we did this
do. I know,
before.
I
We did this
know.
before. I kind of like JAMA. He says JAMA, whatever. This is one of those rational clinical exam articles, which actually now are books. Did you know that the rational clinical exam is now actually a series of books, which is kind of interesting.
Also known as medical school.
Yeah, indeed. Well, there's that. These all start with one or two, sometimes 3 case scenarios that hit on what is it we want to know about trying to diagnose a particular entity. So this one.
2 cases.
This had 2 cases, this one did. And it looked at trying to diagnose osteomyelitis in diabetics. And it wanted to know, is there anything in the history of the exam, in our workup or testing that really helps us say, yes, it's diabetic osteomyelitis, or it isn't, or it's osteo in a diabetic. So we know, and gosh, those of us who work in emergency departments really know, that foot-related complications in a diabetic are horrendous. We see, oh my gosh, I think I admitted 4 the other day, to the point where we even have now a foot protocol that we have in our hospital. That's how we approach all these people.
Yep.
And you've seen the poor diabetics that come in as they're getting whittled away one toe at a time. It's the most common cause of non-traumatic amputations, and it's not benign. Their perioperative mortality from all the things that go with being a diabetic is as high as 7.5%. It's pretty significant.
And part of it's their infections, part of it's their vascular disease.
Right. They have bad hearts, bad kidneys.
I don't know if you've ever heard the description of the vascular surgeon's job,
oh, dear.
which is. Their life is summarized as fem pop, 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 chop, chop, which is the bypasses and then the amputations.
For us, the problem is that we really need to find out if a diabetic has osteo or not, and we have to figure. There's no gold standard in this. We have to accept a biopsy, which we don't do in the emergency department. So we'd like to be able to say, yes, you are more likely to have diabetic osteo than you are. So this paper was kind of looking at trying to do that. We know there's certain historical findings out there, things like how long have they been diabetic, are their sugars well controlled, do they have signs of disease? Right, exactly. And do they have retinopathy? Do they have nephropathy, which tells you they already have some vascular disease? Are they neuropathic? Do they have trauma? Do they walk in bad shoes? Do they have a history of all of those will sort of give you an idea of the risk of osteo. And then when you do your exam, you're looking for things like, are they infected? Do they have SIRS kind of stuff? Are they febrile, chills, hypotensive?
Noting that in fact sometimes they won't have a fever. Noting that they may not complain of pain because of their
which is what this
neuropathy.
paper is trying to look at. Is there anything there that really will help us? And is there anything about the wound itself? Does that smell you can smell 3 doors down mean it's osteo or not? Tenderness, neuropathy, all of that stuff. Those physical exam findings, do they help us say osteo or not? And then the ulcers themselves, they're actually 3 different types. One is venous, one is arterial, and one is diabetic.
Now, I thought this was good stuff.
This is great, actually.
This is kind of good stuff just to hammer out.
Plus, it's also good stuff when you're in the emergency department. I find this very helpful when I'm looking at ulcers to kind of figure out why does this person have one. A venous ulcer, sort of the venous stasis ulcers that we sort of lump into that category, tend to be irregularly bordered and on the malleoli. Okay, it's actually a thinner area.
It's a great picture of it too.
It's a thinner area of where if you look at your own ankle, that's the thinnest skin around your ankle, and that's sort of at the biggest risk of when there's sort of venous stasis of just having a poor sort of getting rid of the blood supply problem. That's where it breaks down. Arterial is different, though. It tends to be the end parts, toes, shins. The borders are pale because it's just not getting a lot of great blood supply. And it looks like somebody took a hole punch and punched a hole out of your skin.
Yeah, look at that 4th toe. There's a white circle there that's gonna be a hole punch.
It's perfect. It's perfect, and it doesn't heal well. Lack of granulation tissue. So if you think about that, you've seen a gazillion venous ulcers where it's all meaty in the base and really well healing, and the arterials aren't. They look kind of dry. They hurt like a son of a gun unless they're neuropathic, which diabetics often are. Diabetics ulcers, they can have arterial problems and venous problems, but the diabetic ulcers tend to be areas of pressure. So it's where the shoe is rubbing on their toe. It's where their bunion is rubbing on their shoe. That tends to be its pressure areas that are diabetic ulcers. And there can be combinations of this. But in general, I love this sort of differentiation to kind of help you know what to worry about as far as diabetic ulcers.
Now, I can't help but look at that bottom picture, and it's like, is that stigmata or is that diabetic?
I know, it's not great. I love that picture. That's just a bad pair of shoes. Now, we do things like stick stuff in holes. So there's a hole in the bottom of the patient's foot. Let's stick something in there. There's a thing called the probe to bone test, which a lot of us have done. Now, taking a Q-tip And sticking a Q-tip in there is not a probe-to-bone test. A probe-to-bone test is something that's metal, or at least something that's hard, that if you put it in the hole, it hits bone and hits nothing in between. It just goes right to bone. That's called a positive probe-to-bone test. It's meant to be with something metal. But if you have a Q-tip, don't use the squishy part. You really want to make sure you're hitting something hard with something hard, and you can feel the difference. And then some people will say, well, a bigger ulcer is more likely to be osteo, smaller ulcers less. These are all things at our disposal to determine whether somebody who's diabetic has osteo. What this paper wanted to do, and again, it's one of those rational clinical exam papers, is they went to the literature and said, let's come up with papers that look at diabetic osteo and see what kind of things fall out to help us or not.
And some of the things that they found were shocking to me.
Oh, it's actually really interesting.
Like, none of the papers looked at fever. I'm like, really?
Oh, exactly. Exactly. And they did do a pretty good, so when they pulled all these, they went to gazillion papers, they did a literature search. Their reference standard had to be a bone biopsy and culture or histo results that showed it was truly osteo. So they used a nice standard in this, and they didn't do kids, they didn't do mixed patient
disease,
populations,
yeah.
Some had diabetes, they just right to the diabetic. So it's good. And they came up with 21 papers, which all things considered, these kinds of things usually come up with 5 or 6 or 8. 21's a lot. About 1,000 patients, ranging prevalence. But here's sort of what
so
they...
if you go back and look at the prevalence, though, you know that there's going to be a little bit of apples to oranges here. Because
12 to 100%.
If you see 100% prevalence, then the likelihood
That's a selection bias.
There's selection or incorporation
There's
bias or
wrong
something
there.
going on.
Yeah, exactly. But that being said, they kind of tried to pull this together and come up with things
Yeah,
called
I think they
likelihood
did a good
ratios,
job.
which is what we look. These kinds of papers come up with a number, and the bigger the number, if it's a positive likelihood ratio, the more helpful it is. The lower the number, if it's a negative likelihood ratio, the more helpful it is.
And sort of keeping that in perspective is worth doing. So if the likelihood ratio is 10 or 0.1,
that's awesome.
That really means that this is a clinically useful thing to you.
Very helpful thing.
If it's sort of 4 to 10, that means there's some discriminatory value to you. It might have some yield depending on where you were using it in your evaluation or schema. But numbers sort of between 1 and 4 are not that good.
They're not very robust.
They're not that good. And the same as you on the other side of the scale if you're
right.
to do
and
it.
It's interesting. You'll see in this paper, and actually in another one we'll do in a little while, how this makes a big difference in how you interpret this data. Because you can spin it if the positive likelihood ratio is 1.5. You can say, woohoo, it's 1.5.
We found something. That's not good enough.
But it isn't good enough clinically. So
right. So
Billy's
10
point
really
is very
good. 4 to 10 means it's pretty good. It might help you. Less than 4.
And the same thing with this sort of 0.1 to 0.6 range, going the other direction.
Right.
Same kind of deal. So just as Billy was saying, this idea of fever. There were no studies that looked at any of the historical components at all. None of them. All of them looked at just physical findings and tests. So I can't tell you if they said I had a fever.
I look at this, I'm like, what are we, a bunch of slouches?
Right.
What is this, not a big enough problem
papers.
to study? They
Nobody
couldn't
did
find
that.
a single thing?
I don't know. So that somebody forgot to look at that. So hello, people who do research, go back and look at that. Now, as far as what you got on exam, this is different from I complained of a fever, but here, when I'm in the ER, the temperature, we know this, clinically you know this, the sensitivity was 19%. Only one study even looked at it. We know that a fever in a diabetic for osteo is not very helpful. Now, bone exposure, if their entire bottom of their foot is hanging out with bone, the likelihood ratio on that went up to almost the range Billy is talking about, which is 9. Which is, yes, I'm glad they reported it, but really?
Yeah.
Really? I mean, it's just right there, of course. Now, ulcer area, I kind of like this one.
They could have added, and if the bone smells bad.
Exactly. And it's really squishy when you poke into it.
There were no studies that addressed sense of
and
smell.
smelly. No, they didn't, which surprises me because we all use our noses in this. Ulcer area, the bigger and then the cutoff was about 2 square centimeters.
And that's pretty good discrimination. So 0.4 on the, or 0.5 really on the low end, and 7 goes, so that's, that's the kind of thing that says, all right, that's approaching a discriminatory value that's useful to me.
Right, and if it is bigger, that is at that likelihood ratio 7, I'm kind of good with that. That one's pretty good.
Yep.
Now, probe to bone test, you would think this would be like off scale fabulous. Turns out it's not, but it's still pretty good. Overall likelihood ratio was 6.4. So if you were able to probe to bone, it was in that range of, okay, well, that's pretty good.
And
the
a lot of
negative
people
was
looked
good.
at that paper when it first came out and said there were all kinds of problems with it, but it was so, in many ways, common sense based. I mean, someone had to go and do the numbers. But I think it showed what your common sense would have told you.
Right. And I like the clinical Gestalt because you're given credit for having some clinical Gestalt. And your likelihood ratio is not half bad. It's about 5.5 as far as your clinical Gestalt.
Yep.
Now, if you get to tests that we can do, a SED rate, that one is out of the park. It's a likelihood ratio of 11. So if your SED rate is over 70, which makes sense, the three things that cause super elevated SED rates, one, basically chronic infections, one of which is osteo. Osteo is way up there, a huge one. Increase your SED rates. Things like polymyalgia rheumatica increase your SED rates. All of these things that are chronic inflammatory states bump your SED rate high. So this one is great. I don't like SED rates, but in this instance, it's actually particularly helpful. White count, forget it.
And pretty good discriminatory value.
Yeah,
as we
it is.
said.
Both directions. Both directions. Now, white counts, we know. I hate the white count. I hate the white count.
But you're getting the blood. It's not like you're going to not send a white count. So
but,
go
but
have
don't,
at it.
But it doesn't help
don't
you
hang
one
your
or the
hat
other.
on it. Don't
Not
say
at
it's
all.
7, so it's
and
not.
I love this swab culture. The cooties that grow and all the gunk around
Yeah.
the actual osteo isn't necessarily helpful at all. You want actually to bite some of that bit of bone out of there. Now, films, if they're positive, which is actually, you would think that if the films were positive for a loss of trabeculation, they're missing part of their metatarsal head, you would think that would be a slam dunk. It isn't actually. The positive findings, the likelihood ratio is 2.3, which actually in a diabetic makes sense. They often have a neuropathy as well. They often will have things like Charcot joints, which are not infectious. That's just destruction.
Right.
And they have vascular problems
they have
to the bone.
loss. And
exactly.
all kinds
So
of
this
things.
actually makes some sense. You would think that, oh gosh, there's a whole piece of bone missing. It must be osteo.
And then
Not so much.
periosteal reaction, which might be more specific to infection, is pretty uncommon.
Right. So this is, I thought this was
Certainly in
great.
a foot. If you have a longer bone, like a tibia, where you got a little length of cortex to look at, then you're more likely to see
see the little-
periosteal reaction.
Right.
But in foot bones, it's hard.
So this falls, both positive and negative, kind of falls in the range that Billy was talking about, which is really
Not so
not
good.
wildly helpful.
Again, you're going to do them.
Right.
Of course you're going to do them. But don't try and hang your hat on that or the white count.
Yep. And then soft tissue culture. So again, scooping out the goop around there. First of all, they only identify the pathogen in the best of situations a third of the time. So that's not considered reliable. So that's not so good. And again, we can't do bone biopsy cultures for us to help us in the ER, but we can image. And it turns out that the bone scan, which we don't usually get in an ER anyway, isn't particularly helpful. But an MRI is pretty good. Not fabulous in the likelihood ratio as far as positive, but okay, but great on the negative.
Yep.
So great negative likelihood ratio. If it's not there on the MR, odds are it's not osteo, which is actually very helpful in that
helpful.
regard. So here we are. Useful findings to rule in disease. An ulcer
ulcer.
greater than 2 centimeters squared. Probe to bone test, positive. SED rate greater than 70. Positive plain radiograph and MR results. Helpful. Okay, helpful.
Del bingo.
Forget the temperature, forget sort of a presence of local inflammatory changes doesn't change, forget white blood cell counts doesn't help you, and a swab culture don't help you.
These are sort of, this slide is about sort of the fixed false beliefs that you will hear from consultants.
All the time.
Yeah,
Right.
These
Well,
are,
they weren't
this
febrile,
is
it can't be.
This is the fixed false belief page, and I like
Exactly.
it for that reason.
And I like this. This is a very meaty article, I think, for questions, so pay attention to these, because I think there'll be a good question or two out of this one.
And it's common,
It is very common.
hugely common.